There are two projects that we have set up in the last 3 years in addressing this. There are two things which are important about these projects, which set them apart from professional initiatives that we have been involved in the UK over the last 20 years. Firstly, these are located outside of the state sector. We believe, or we have come to believe, after several years of working within state agencies, that if we want to improve the services that are available to our communities, particularly for migrant communities, for black communities, then we have to locate outside of state or professional apparatus that controls these communities. It's a question of legitimacy. Where do you belong? Who do you belong to? Who do you work for? And it's a sad commentary on the situation, certainly in the United Kingdom. That question still has a salience. It still has a validity. And when a 15-year-old youth comes across to you, who is known life only in Birmingham, whose parents were born in Birmingham, whose grandparents migrated to the city from the Caribbean, and when that young man looks at you and asks you, who do you belong to? He implies by that I don't belong to whatever you are belonging to. Our National Health Service, a government agency, or on whose side are you on before you can begin to help us? There are powerful forces that are at work in relation to determining the choices that young people make. And one of those is still, unfortunately, about us being different from them or you. And the dynamic is played out very actively in mental health systems. Important to be part of that community, to come from that community, to make use of the resources and capacities of that community in addressing the problems of that community. It is important for professionals like myself, therefore, to make that change and shift. And it's important for these projects to work that it has to be independent. It has to be separate from state interventions. Not to say that we should not have alliances and networks with state agencies, but it's important to locate it outside. Secondly, as many of you will know, when you move away from the state, the immediate problem is that you are made impotent. You have very few resources. You do not have the resources that you have taken for granted. You cannot have psychiatrists or nurses because they're expensive items. You can't even have a building sometimes unless we have a place like Diritti or a charitable agency prepared to provide us with the space. And the way to deal with that, especially in relation to extraordinary resources that we require, such as professional time, these projects are based on volunteering. Individuals, mostly from migratory backgrounds themselves, black professionals, people from South Asian backgrounds who work in the National Health Service, offering their time as volunteers, psychiatrists, nurses, operators, psychologists, volunteering to work in projects outside. And it's very important to emphasize the significance of that volunteering role within these projects. And the first one here is what's called joint experience, which is to ensure community involvement. And the second one is a small mental health project called Sukoon, which means in Urdu means a place of safety. Very briefly about joint experience. It has an Italian connection because this is connected with the initiatives by a mental health association in Tuscany and a mental health association called Lanarkshire Links in Scotland. It's a collaboration between two mental health agencies, service user organizations, where service users have come together to determine the nature of the services that they want to develop. A very simple model. A model that is about reshaping care and support by moving the agencies that provide support and care within the statutory sector, within the National Health Service, and taking over those agencies to provide support and services for people in the community. And this does that, the agency does that through community asset mapping, through community engagement, using community capacity, resources and spaces and facilities that are available to the community and making use of those facilities for looking after, supporting people with mental health problems from within those communities. Many people would say a very simple formula, but a formula that has escaped many of us working within professional agencies. And we have been able to work towards re-empowering the community agencies who had so far been neglected and excluded in the context of professional development. And the joint experience is shared experience between professional agencies and community agencies. Sukoon, similarly, is a project that has arisen as a result of a demand, particularly from minority communities living in Glasgow. Major problems with the people of Pakistani background who have been living in Glasgow for 50, 60 years. Glasgow is a big multicultural city. Substantial proportion of the local population is of South Asian origin, particularly of Pakistani origin. And as you can imagine, with most migrant communities, very high levels of deprivation, poverty, social marginality, exclusion, and discrimination through generations. And people who experience mental health problems either reluctant to approach mental health services or afraid to approach mental health services. And people often say, well, what we need to do is address stigma about mental illness in these communities or raise awareness about mental health issues in these communities. Strategies and policies that have failed over the last 50 years to have any impact in terms of improving the trust or engagement with mental health services from minority communities. It is not surprising. You cannot really encourage people from black communities to use mental health services when the actual experience of mental health services by these communities is irredeemably negative. That if you enter into these facilities, you become trapped in those facilities. You receive coercive and negative care. You are detained forcibly, treated forcibly, and your rights are seriously compromised. At the end of it, when you leave the services, for example, when you are discharged from hospital, families are appalled at the consequences of the so-called professional interventions, which by and large appear to be centered around medication, and more physical treatment. And reinterpretation of one's personal experience as entirely to do with an illness and how to manage that illness, and completely ignoring the social, cultural, personal context of that. And then to say that you can do an education program with a community to make them change their mind does not make sense. But of course, a significant mental health needs in our communities. It is not to say that people do not suffer. It is not right to say that people do not have mental health difficulties. How do you access that? And Sukoon is a model that provides that. Again, it locates itself outside. It uses volunteers, psychiatrists, and other people who have committed to addressing these problems differently. And we worked with the local community resources, such as the local mosque, which is a very powerful center for spiritual help for individuals from that community. Especially in the context of increasing Islamophobia and the equation of being Pakistani with being a quasi or want-to-be terrorist. These centers, these resources in the community become even more important in being able to provide a channel towards appropriate and effective health interventions. And this particular project involves a local mosque in the sense that they support it and they provide the project Sukoon with a base there, and we can accept people to this project in an unmediated way, by which I mean an individual can make a direct access to the program without having to go through general practitioner, psychiatrists, social workers. Any individual at any point, any family at any point can approach the agency, Sukoon, and seek help. And we can provide appropriate professional assessment, interventions, and support, and also try and work with the individuals and the communities, particularly the families of young people, in actually addressing some of the underlying health as well as social issues. There's also another important element to this project, which is that it provides a possibility of what we call cultural mediation. Many of the individuals who are caught up within our statutory services are caught up in a confrontational or opposition relationship with psychiatrists and their nurses. What some might say, it's an inevitable outcome of psychiatric practice, that many people who receive psychiatric care do not wish to receive that care. Many of us psychiatrists want to give that care. And an oppositional dynamic develops even before you know what happened. But when this dynamic also involves a cultural dynamic about white doctors, white nurses, black patients, black families, the dynamic becomes even more complex. We provide a process of mediation in that context. And some might say, what does mediation got to do with healthcare? You don't want to mediate when a cardiologist gives you treatment for your heart problem, or an orthopedic surgeon tries to fix your leg after you've broken it. Process of mediation. But in psychiatry, mediation is the key to actually ensuring not only that the individual patient receives appropriate care and treatment, because you watch the boundaries, monitor the boundaries of professional intervention, but also you ensure that the professional involved is actually engaging with issues that are important to that individual. So through the process of mediation, which is a formal process where we get involved as independent third parties, and they cannot dismiss me or my professional colleagues from that area by saying, you don't know anything about how the brain works or how this medication works, because we carry that knowledge and information with us, and we are able to mediate effectively, jointly in that particular situation. Some excellent work done in this area, particularly earlier by an anthropologist, Susie Kilshaw, and a psychologist called John Curran in London, in dealing with people in forensic mental health care, where black men, young black men in particular, engage in an opposition relationship which actually only entrench them further within the psychiatric system, and how through a professional cultural mediation and some of these cycles could be broken down. I hope these two projects will indicate the need for more innovative practices in addressing the needs of people from our background. I do not make any claims that these projects provide solutions in the larger context, nor do I advocate them as projects that could easily be transportable or implemented in other settings without any question. But what this does to us, certainly in the context that we work in, what it tells us is that without continuing innovation and a continuing commitment to deinstitutionalization and a continuing commitment to move away from the narrow definitions and methodologies of psychiatry, we are unlikely to be able to address the significant challenges that is being faced by people from our communities. I want to end with a particular quotation from Arthur Kleinman, who is a psychiatrist anthropologist who has written extensively about working across cultural divides. He said, "The focus should be on the patient as an individual, not as a stereotype. As a human being facing danger and uncertainty, not simply a case." And this is an opportunity for us as mental health professionals, as a psychiatrist, to engage in an essential moral task, not simply professional practice. And I will add to that by saying it is not only a moral task, but it's also a political act that you're engaged in. Thank you.